Something interesting, we are going to discuss some outpatient diabetes cases. I'll discuss, these are recent 3 last patients that I saw. I decided to put them up, so I have not kind of muddled around with anything. These are real life patients which have come to me in maybe a day or two, last couple of days, right? So let me go through the step by step process, and then I think we'll get an idea, get a sense of how I kind of tend to manage these patients. There are some patients which were having a longer history. There are some which has recently have come. So that is that kind of discussion we'll have. Let's look at the first case. So this is a 51-year-old male patient, has diabetes, type 2 diabetes since the last 5 years. He has benign prostatic hyperplasia (BPH) and he's planned for a surgery for the prostate. He has history of recurrent genitourinary tract infection. He's an obese guy, 102 kgs with height of 175 and BMI of 33 and blood pressure of 173 by 100. So blood pressure is also high. Okay, so this is the typical profile of this patient. Now look at his investigations. His fasting sugar is 156, post meal is 289, HbA1c is very high, 9.4, creat is 1. He's having microalbuminuria 45, but he's also having pus in the urine. So when you have generally have UTI, you have to be careful that sometimes you may have a false positive urine albumin creat ratio. On ECG, he has left ventricular hypertrophy. Blood pressure is also high, as you can see. His LDL is also high. Triglycerides is also slightly higher. Does not have diabetic retinopathy at present and has mild sensory diabetic neuropathy. So these are the profile of this patient. Now what is he on? Unfortunately, you can see he is having recurrent genitourinary tract infection, yet he is still on dapagliflozin. So he is having sitagliptin, metformin and dapagliflozin, not a very ideal combination, with 2 mg of glimepiride. So he is on 4 oral anti-diabetic drugs and he is nowhere close to target in terms of HbA1c reduction. So this is the patient, right? Current issue is that he is planned for prostate surgery in near future. So not only do we have urgency in terms of glycemic control, but urgency in terms of practical sense also, because he is going to be planned for a surgery. So this is the profile of this patient all in all, right? So what did I do for this patient? Okay, so this is what I did. Okay, so first of all, first question is, does he need insulin? Okay, yes or no? Okay, so answer is yes. Multiple reasons why he needs insulin. First and foremost, remember, if you see the guidelines say if HbA1c is more than 8.5% with 3 or more oral anti-diabetic drugs, you have to give insulin, right? So I think we agree based on the guidelines, and also remember he's planned for surgery, so he has to be given insulin, right? So we agree to that. Question number 2 is, which insulin? So broadly, you have a choice of giving either a premixed or a co-formulation insulin, or you can give a basal insulin. Now you can see here this patient had a fasting of 150 and a post meal of 289. So there is a reasonable difference, I think, more than 100. So I think a premix co-formulation insulin is not a bad idea, but in my practice I generally tend to prefer basal insulin over a premix or co-formulation in most cases. So in this case it could have gone either ways. In fact, could have considered co-formulation also in hindsight, but in this case we probably considered giving a basal insulin. Okay, so next question, what dose? So if you see some of my other lectures and other videos, you would know that I generally start with the Hallman-Turner formula. So fasting plasma glucose minus 50 divided by 10. That is the starting dose of basal insulin that I start in practice. So in this patient, his fasting was around 150 minus 50 divided by 10. So I started the patient on 10 units of degludec. Okay. Now if I had to give something like a co-formulation, that is idec aspart, here also I would generally consider starting 10 units. The difference is, of course, here I give this at bedtime, and here I would have given it before dinner. Anyhow, we started the patient on degludec. Probably again in hindsight, let me say, I would have again retrospectively thinking maybe IDEC aspart would have been better, but it's okay, fine. So we find, so that is one, so right, that is the thing. What about OAD? So he is on a glimepiride, he is on a metformin, he is on a DEPA, okay, and he is on a a DPP4, right, sitagliptin. Now remember, this is an obese guy, so if cost was not an issue, so which drugs I'll skip? DEPA immediately, because the patient already has a GTI and UTI and he's planned for a prostate surgery. So DEPA, and of course surgery itself, 3 or 4 days before surgery you have to stop SGLT2 inhibitor. So there is no way you are giving SGLT2 in this patient. The other drugs we'll discuss in a minute. So would this patient be a good candidate for semaglutide or GLP? Absolutely, right? In fact, either semaglutide or liraglutide, but I prefer semaglutide, of course, being oral agent and convenient to give and better response. Semaglutide would have been a great choice. Only issue is cost, so this patient could not afford, so we decided not to give semaglutide. Otherwise, this patient was an ideal candidate for semaglutide. So fine, we continued this patient on, right, we continued the sitagliptin. So in fact, I gave him a sita plus metformin combination. Okay, so 50 by 500 twice a day. Okay. Now he is on a glimepiride, and I'm not a big fan of glimepiride, especially if I am starting the patient on insulin. So what I did was I switched from glimepiride to gliclazide, extended release. This is my usual practice. Okay, so you can say a little bit of bias, but when you have, so what I do is, when the patient is on 1 milligram of glimi, I switch to 60 milligram of glicla, and if he is on 2 milligram, you get the drift, right? I switch to 120 milligram. So that's, so 60 extended release twice a day. So I switch to gliclazide. Again, you can say personal preference. Third drug which I absolutely love to give is acarbose. Right. So this patient again candidate for acarbose. Yes, post meal sugars are high, so we started the patient on 50 milligram PDS of acarbose. Right. Okay. Let's look at some other situations. Right. So you can see his blood pressure is high. He's having microalbuminuria also. So ARB, good idea. He was taking amlodipine, so we switched to ARB. So we telmisartan with amlodipine combination. Blood pressure is still high, right? So we need to control that as well. Does this patient require statin? Absolutely, right? LDL is high, very lot of multiple risk factors, so statin. In fact, this patient is for high intensity statin, so we give rosuvastatin 20 milligram. Okay, so statin is absolutely required. Does he need something for neuropathy? He has mild neuropathy, so no. Give them B12. Fine, we'll see, right? So he's just saying mild neuropathy. He's having a little bit of UTI, symptomatic, so that needs to be treated. So these are the things we look at, right? So my final prescription for this patient would have been something like this. So yeah, so the prescription for patient number 1, right? So you have insulin, degludec, 10 units at bedtime. Second, acarbose, 50 milligram TDS. Third, sita plus metformin combination, 50 by 500 PD. Next, right, would give this patient a gliclazide, (60 milligram XR preparation twice a day. Okay. Fifth, telma with maybe cilnidipine or amlodipine. Fine. I think I use cilnidipine maybe because of microalbuminuria. But like I said, you would actually have to repeat the microalbuminuria. But yeah, so telmisartan with cilnidipine, 40/10. Okay. Rosuvastatin, 20 milligram bedtime. Okay. So yeah, since it's planned for surgery, aspirin not debatable. Anyways, planned for surgery. So right now, in fact, you can give aspirin when the patients these days, but did not start the patient on aspirin. So these are the things. So give something for the infection and then B12, right? So these are the things we prescribe to this patient. Okay. Now, how will I follow up this patient? So this is a fresh patient. So I would ask the patient to check the fasting sugar. Right, fasting sugar daily, and then need to send by WhatsApp, and then you can titrate the dose of basal insulin based on the fasting sugar. And my idea would be to target the patient's fasting in the range of 40 to 90 to 140. Okay, so this is how I'll manage case number 1. Let's look at case number 2. Very interesting patient. So again, recent patient, but this is a retrospective management, right? So let's look at it that perspective. So 64-year-old male patient, this is when the first time he presented, I think presented in January or December. He has chronic liver disease, right, hepatitis B related, compensated, but he is having hypothyroidism, weight is 77, SGPT is 17, compensated as LDL is high. This was the initial presentation, fasting of 230, post meal of 380, HbA1c of 9.5, creat of 0.7. Okay, so he has chronic liver disease, remember, right? So he was on premix insulin, 18 and 16, right? So 18 plus 16. Okay, so I am very good at bad at math. Okay, so 34 units total insulin he is taking. Okay, he is on metformin with DPP4 inhibitor. Now, despite this, all this situation, his glycemic control is less than ideal. In fact, not control at all. So what do we do with this patient? Okay, so first of all, again, not a big fan of giving premix insulin twice a day. Not a fan of NPH insulin. So I decided to start the patient on again basal insulin. Again, Decludec. Now, remember, he is on 34 units of insulin, but he is not controlled technically. So if you take 70% of 34, comes to around 20 plus units. So again, bad at math, right? So go with that, right? But remember, his sugars are very high, so I kind of decided to chuck that out of the window. Go back with our age-old Hallman terminal formula, 232 minus 50 divided by 10, right? So it comes to around 318, right? So decided to start the patient on 18 units of Decludec. It will of course require higher dose. What about other agents? Okay, so he was on, already on metformin and DPP4 combination, which I continue. Okay, the patient was on metformin with DPP4, so we continued that. Now you will ask me, is DPP4 and metformin safe in chronic liver disease? Remember, this patient is having a compensated chronic liver disease. Decompensated, apart from vildagliptin, you can actually give the other gliptins. So the gliptins are safe, right? But vildagliptin, there is some safety concern in chronic liver disease, so I would not give vilda, right? This patient was on sita again, so we continued that sita with metformin. Third, would this patient be given SGLT2? Can be given, right? But generally with this high sugar, I generally don't start sita with SGLT2 straight away. So generally wait for some time and then add a SGLT2 later. Get some blood sugar control better initially. So that's the idea. Again, acarbose, you can't do without that. Okay, so started the patient on acarbose. I also give such patients, the triglyceride in this patient was also high, 230, but from a lot of perspective, again I give saroglitazar to a lot of these patients. So remember, it has liver protection, Triglyceride of this patient was 232, so it was high. Again, it works as an anti-diabetic also. This patient is having glucotoxicity and lipotoxicity. So this also gets broken down by saroglitazar. It's helpful in that situation. So this patient was on saroglitazar also. Very importantly, what you have to consider is insulin technique. Okay. One of the major challenges in patients like this is insulin technique. Always remember this, right? This is a major trope in such patients. They have a poor insulin technique, and because of the poor insulin technique, this patient is taking such a lot of insulin, yet the sugar control is. True to that, this patient had that challenge, right? So we corrected that. So my final prescription in this patient was Decludec 18 units, Sita plus metformin 50 by 500 BD. Okay. Third was Decarbose. As you can see, I am not adding a, I am not compelled to add a SU, so I am not adding a SU, and a saroglitazar 4 milligram. Generally give it at bedtime. I think his LDL was high, so statin also, and antihypertensive as per, and he was also hypothyroid also, so maybe that also required correction. So this is the diabetes perspective, right? This is the treatment. Now, what do you do next? Ask the patient to report the fasting sugar by WhatsApp. Target again being 90 to 140. Okay. So let's say patient had fasting sugar of 232. Next day he reports as 200. What do I do? Again, if you have seen my earlier presentations, you know that when the sugar is coming down, I don't increase the dose of insulin. So I continue same unit, 18 units. Next day it comes to 190, same 18 units. Okay. Next day comes down to 194. So it has increased or remained the same, then increase the dose. So increase to 20 units, so on and so forth. So ultimately, with close to around 24 units, the fasting sugar was achieved around 130. Okay, which was within the target. Now, if you can see the patient's HbA1c trend, right, this is the outcome. Started with this HbA1c in, I said, January, right? And when he first came on follow-up, his HbA1c was already 7.5, that is in March, and then now it's come in May again, and you can see HbA1c is now less than 7%, right? So I think beautiful control. You can clearly see this is a real life case. You can see how well the control was. So we did nothing actually. In fact, just put the patient on basal insulin, switch some oral antidiabetics, played smart, titrated the insulin dose. In fact, now he's on lesser dose of insulin than he was taking earlier, with better glycemic control without sulfonylurea, right? So that is also something good. Okay, so that is the situation in this patient number 2. Let's look at the most interesting of the 3 patients. That is patient number 3. Okay, so this is a young boy. I have not put too much details here. I'll add along as I go along. So it's a 26-year-old male patient, right? So young boy who presented. Now, very interesting story. Okay, so he first, I actually looked. We just discharged him yesterday, so hence it's fresh in my mind. So I thought I'll include this case. That's why I don't have all the details also, because before I could make the presentation, discharge process was still going on. So when I looked back at his records, I actually wanted to see when did he first present. He actually first came to me in 2019. Okay, that time he's 26-year-old, so I think he was around 22. I think that time 22 thereabouts. Yeah, 21, 22. Okay, so around that age. Now he came to me with severe hyperglycemia. Okay, he walked into the OPD, but blood sugar was 500. Ketones were positive. Okay. So young male, young patient presenting with severe hypoglycemic ketone. What is this? So we assume this patient is having diabetic. He has diabetic ketosis. He had in fact had acidosis also. Diabetic ketoacidosis with type 1. This is in fact the diagnosis that we put, right? So we admitted this patient. Right, started him on IV fluids, potassium replacement. Okay, what else? Then we also give this patient insulin infusion. This is back in 2019. Okay, started this. Now with this correction, gradually the patient's blood glucose improved and ketones came down. And one good marker is anion gap, right? So anion gap is a very useful marker for looking at the patient's improvement in terms of diabetic ketoacidosis. So the patient's anion gap was also coming down. Okay, so we kept into that process. Now, so this is the process that we looked at. Then once the patient was able to take orally, there was a little bit of abdominal discomfort and all that. Now we could then assuredly patient could take orally, you switch the patient to basal bolus insulin. Okay, now how do you switch the patient to basal bolus insulin? Okay, so again this is something we had discussed. So if the patient is on IV insulin, now let's say what you do is you take the last 6 hours infusion rate. So let's say last 6 hours average infusion rate was 2 ml per hour. Okay, so 6 into, right, so this is 2 ml per hour, right. So and then you have to multiply that into, so you have to take the average of the last 6 hours. Let's say average came to 2. Okay, so 2 ml per hour was the average rate in the last 6 hours. You have to extrapolate this to 24 hours. Okay, so okay, so 2 into 24, right. So 48 units was the total dose in 24 hours. Of course, not exactly, we have extrapolated just the last 6 hours to 24 hours. So 48 units the total dose. Okay. Now, what you have to do is generally you take 80% of this, right, 80% of this total dose, right, and then you have to divide it to basal bolus. Now again I am very bad at math, so let me use a calculator actually. Okay, let's do this. Let's ask ChatGPT. Okay, yeah. So this is the new GPT-O, right? This is the ChatGPT app. Okay, for MacBook, and this is the GPT-4o. Okay, what is the 80% of 48? Okay, so it's doing the calculation. So 80% of 48 is 38. Okay. Now 38 is the dose of the total dose of insulin. Okay. So of this you have to give 50% basal and 50% post bolus. So what is 50%? This is easy math, but now we have opened up ChatGPT. Let's use it. Right. So it is 19. Okay. So average it out. Let's say we put it as 18. Right. So 18 units of basal and 18 units of total dose of bolus. Okay, so total dose of 18 units of basal. So insulin, let's pull this notes up. Okay. So 18 units. So my prescription will be injection degludec 18 units. I generally give it at 7 p.m. when hospitalized patient, and injection faster aspart of total 18 units. So 6 units before breakfast, 6 units before lunch, and 6 units before dinner. Right. So this is how we generally do it. Now after that, you ask the nursing staff to check sugars, before meal and bedtime. Okay, and then we target the pre-meal sugars to 90 to 140, and post-meal generally less than 200. Okay, so this is what we did. Then we discharged the patient on the same, more or less, after titration. The patient was discharged on more or less this type of thing, right? And patient kept reporting the sugars to me 4 times a day initially, before meals and bedtime. And this was what he reported to me. Right. Now, what happened interestingly for this patient was, so what happened was that the patient had a very stable blood glucose. So this was a little surprising for me. Okay, patient having a very stable blood glucose is sitting over type 1. Type 1s generally tend to have a little bit of variability always, right, because there is a lack of glucagon also. But it can happen in a newly diagnosed patient with type 1, it is quite possible. But anyway, so what we did was we called the patient back after a few weeks. And at that point of time, we decided to do, that time when the patient came, his fasting sugar used to remain, so everything was under control. Okay. So we decided to do what is known as a mixed meal stimulation test. Right. Now, again, you know, we have discussed this in some of my earlier presentation also. I think I have we actually made an app also. Let me check. Okay. Something called endodynamic. Let's see if this works out. So we're going to put this app, post it very soon. So we, I don't think we have made some other things, but let me check. Yeah, okay. This is my Python app for mixed meal stimulation test. You can pull this up. So I don't remember the exact values, but what we do is we do the fasting blood glucose and the fasting C-peptide, and then we give a liquid meal, and after 90 minutes we do the blood glucose again and we do the C-peptide. So his fasting blood glucose was around 90 and his fasting C-peptide was, let's say, 1.2 nanogram per ml, and then post meal sugar was around 180 and post meal C-peptide was around 2.3. Okay. So let's say, so we have a calculation, right? So it says, this is the thing, post meal C-peptide less than 6 is a strong indicator for insulin requirement. So this patient definitely requires insulin, but we do a score, we have this proprietary scoring system where the score is 1. So it says it's unlikely to be type 1, but follow up is required, right? Which is very interesting. So he's actually having reasonably amount of good C-peptide, which is quite interesting. Okay. So this patient is having a good C-peptide, right, good endogenous insulin production, right, but he presented with ketosis, right. So again, benefit of doubt is still that he is having type 1, right. So he also said a GAD antibody. If GAD antibody was positive, I would have strongly favored type 1, but it was negative. So now you have this patient which is technically classified as antibody negative with beta cell positive. So he is having beta cell function with negative antibody. Now this could happen in what situations, right? So this could happen in type 1 with or a LADA in a honeymoon phase, right, where the insulin production is recovered. Right? So he's honeymooning, right? He's going into what I like to say is honeymoon. He's going into a honeymoon phase. It's not completely there. He's going there, right? So he's going honeymooning towards it, or it could be ketosis. It was just a ketosis prone type 2, right? It could be that. Could be modi, but you know, less likely, right? So it could be a ketosis prone type 2. Okay. So what we did was we again carefully started withdrawing one short acting insulin gradually and started replacing with OAD. So then patient was eventually on basal plus OAD, and we put initially on acarbose, again my favorite, with sita, and then we added metformin, right? Again very typical thing. Don't give SGLT2, don't give SGLT2, right, for such patient, because if you give SGLT2 you are actually asking for trouble. Okay, that is one of the major thing, because patient can go into ketosis, you are still not very sure what type of diabetes you are dealing with. There is still that hesitancy here. So we started withdrawing that, eventually even gradually slowly started withdrawing everything, right, and in the end this is somewhere in 2020 or 23. My last prescription was, he was just on acarbose plus metformin, 50 by 500 once a day. He was just on this. Okay, he was maintaining good glycemic control. So what I told him was that don't stop checking, because this could go bad again. Don't stop checking. Okay, so he agreed, right? Unfortunately, like every other human being, he lost track. Came back to me just a few days back, saying that, sir, I think I am in ketosis again. Right? I have the same feeling that I had earlier. True to it, his random sugar was 472, and ketone was again positive. Okay, but thankfully he did not have acidosis, he just had ketosis. Ketosis, no acidosis, but we still admitted him, started the whole process again and discharged him on basal bolus. Now you'll ask me whether this is still type 1 or this is still a ketosis prone type 2. I'll tell you honestly, I don't know. Okay, we are still treating this like type 1 again, just like we did last time, right? But the fact that there are two things. One is, so what I would say is that, if you see some of my other videos also where I talked about the unifying theory for pathogenesis of diabetes, this is where I often say that this type 1 and type 2 is what we have put as, classifications. End of the day, your patient is your patient, right? Your disease does not know this classification. So what you have to look at is the beta cell function and the insulin resistance. Now, if there is more of beta cell function which is lost, right, if this is a predominant problem, right, so hence you are dealing with more of a type 1ish type of picture. If insulin resistance is the major problem, you are looking more at type 2, but then there are a lot of patients who fall in between the spectrum. So it's probably not type 1, he is probably a more severe form of type 2. But his beta cell function is very poor, so keeps going into ketosis. And what he went through the second time also was what I often say this, it is glucotoxicity. Let me put it in bold letters here. This is typical glucotoxicity, right? You have to understand. He goes, now if he had kept checking his sugar and sugars had started going up and he had reported that to me, we would have slightly increased acarbose dose, maybe added a sitagliptin again, right? I would have probably prevented the patient going into this glucotoxic spin. But because he did not check, he did not report, the patient went into glucotoxicity, and that is where the problem really lies, right? Now, of course, is discharged on basal bolus. Now, we are going to again do that process of shifting. We'll see how it goes. But at this point of time, this is how we are typically looking at in this patient, right? So it's a very interesting case. You will see a lot of these patients in your practice. Similar to that, right? Again, you would not directly label this as type 1 or a type 2 or something, right? It's somewhere in between. It's a very interesting. I've seen a lot of patients of this type in my practice. In fact, this is exactly, I had another patient exactly the same like this. And recently I switched him over from basal to basal, basal bolus to basal plus OPD. He's actually doing well. Again, young patient, similar age group. I'm actually looking at how he's going to evolve, right? Let's see. So he's keeping a close watch, and we hope for the best.